What about now? So I think the video is no longer paused now. So I think I've started recording. Yeah, the video is not paused now. Can you observe that? So that for people that will be listening to the recording, they can actually see the, what's it called, slide. All right, thank you very much. Okay, good. All right, so some people have responded. Pharmacokinetics. Okay, it's the study of what the body. Okay, it's a branch on what the drugs to the body. Okay. Let me see. Absorption, distribution, metabolism, excretion. Yeah. Of drugs in the body. So what the body does to the drugs, yeah. So that's another simple term. What the body does to the drug, or is the pathway of the drug throughout the body? Okay. Yeah. Okay. So thank you very much. All right. So now we'll be looking at each of these components one by one. So I gave you an acronym during the last class, which is ADME. ADME. Absorption, distribution, metabolism, and excretion. So absorption, distribution. So now let's look at drug absorption. So what is drug absorption? So when we look at the slides that is displayed on the screen now, so what is absorption from that? Absorption simply means the process that the drug moves from where it is given in the bloodstream. So from where it is given in the bloodstream, so that it can start working in the body. Okay? Please, how many people can see the slide? Because that is one of the challenges here. Can we see the slide? Can we see the slide that is on now? The slide that is on now is drug absorption. Can everybody see it? So if you are not seeing it, it's network. Oh, there's nothing I can do. Yeah. So it's network. Sing. So if you are not seeing, kindly log in, log out. And if you can hear, just listen. Just listen. Yeah. Sing. Okay. So now, for example, now when you swallow a paracetamol tablet, it dissolves in the stomach. It dissolves in the stomach or in the intestine, and then the medicine is what? It's now absorbed into your bloodstream before it can actually reduce fever or pain. Are we together? So that's the definition of absorption. So now let's talk about factors that affect absorption. We are going to talk about physiological factors. We are going to talk about, you can jot. So we are going to talk about physiological factors that affect drug absorption. So I'll just explain briefly one after the other. So what are the physiological factors that can actually affect drug absorption? We have the gastrointestinal pH. That's the intestinal pH. So, or alkalinity of the GI tract. So the acidity or the alkalinity of the GI tract affects drug ionization. It affects the solubility of the drug. So take, for example, a drug that is weak acid. Aspirin is an example of weak acid. That one absorbs better. You know that aspirin is an example of weak acid. Our acetylsalicylic acid. So it's the weak acid. So such a drug, when the patient takes it, it is better absorbed in an acidic stomach. Are we together? So now, drugs that are weak bases, they are better absorbed in alkaline parts of the body. So can you tell me the part of the intestine that has that is alkaline in nature? Which part of the body is alkaline in nature? Which part of the which part of the GI tract? Thank you. The intestine. Thank you very much. Intestine. So now weak bases absorb better in alkaline small intestine. Are we together? Or if you give a patient aspirin, it is better absorbed in the acidic stomach. So that's just what we mean by gastrointestinal pH, acidity or alkaline. Now let's go to the second one, which is surface area of absorptive surface area. So now what we mean by this particular point is that the larger the surface area, the greater the what? Absorption. And we know that absorption takes place majorly in the small intestine. There are some finger-like projections in our intestine, which is what? We call it microvilli in the small intestine. So, and we know that small intestine is the primary site for oral absorption of drug. For absorption of oral drugs. Are we together? So the larger the surface area, the greater the absorption. So that is what I'm trying to explain. The larger the surface area, the greater the absorption. Are we together? Then number 3 is GI motility. Gastrointestinal motility. So we are talking about, okay, is this slow? What happens to drug when there is slow motility? What happens when there is fast motility? So now, for slow motility now, will drug be absorbed faster or slower? Let me ask first. When there is slow motility of the GI tract, when there is slow motility of the GI tract, do you think drug will be absorbed slower or faster? Slow motility. No, there will be more contact time, so there will be more absorption. That's just it. When there is slow motility, there is more contact time with that drug. So there will be more absorption. Yes. There will be more absorption. With slow motility, there will be more absorption. Although some drugs although it may increase the degradation of some drugs that are unstable. But when there's slow motility, there is more contact time, so there will be more absorption. But with fast motility, take for instance, a patient is having diarrhea. So let me put it that way. Take for instance, the patient is having diarrhea. Is that not fast motility? Is that not fast motility? That will reduce the absorption now. That will reduce the contact time. Before you know it, that drug is out. So that will reduce the absorption. So thank you for understanding. So now let's go to number 4. Blood flow to the absorption site. Blood flow. Blood is very, very important. It plays a very important role in absorption of medication. Blood flow is very important. So when there is good blood supply, that means that blood will carry absorbed drug away quickly, which is synonymous to what? Faster rate of absorption. So that means it is going to maintain a high concentration gradient for more absorption. So when there is good blood flow, there will be what? There will be faster absorption. There will be faster absorption. So now when there is reduced blood flow, maybe maybe a patient is in shock, or something has actually caused or break the flow of blood, then definitely there will be slower rate of what? Absorption. So do we get my explanation? Do we get my explanation? So anything that reduces blood flow will reduce absorption. So now let's move on. Presence of transport systems. Presence of transport systems. So when we are saying presence of transport system, there are some drugs that require some carrier proteins. Or active transport. You know, we have active transport, we have passive transport. Maybe from our knowledge of science, biology, you know, we have active. So there are some drugs that require carrier proteins or active transports. So the presence of this transport system also determines whether absorption will be fast or whether absorption will be low. Take for instance, there is a drug we call levodopa. Carbidopa levodopa. What type of drug is that? Who can tell me? There's a drug we call levodopa. What do we use it for? So I want to use that drug as an example. So that we can understand what I'm saying. Who knows what we use levodopa for? Levodopa, carbidopa. Hello, I hope we are still together. Can you hear me? Yeah, it's dopamine. Yeah, I know. It's dopamine. From the word levodopa. So what do we use it for? Thank you. We use it for Parkinson's disease. Thank you. So this medication now, I'm just using this as an example. It's an anti-Parkinsonism. Thank you. So this medication now uses amino acid transporters in the intestine. So this medication uses amino acid transporters in the intestine. So there are some medications that actually require transport system, maybe active transport or passive transport. Are we together? Okay. So now presence of enzyme is another thing. Presence of enzyme is another important factor. Now, when we are talking about presence of an enzyme, There are enzymes in the GI tract. We have a lot of enzymes that plays a role in absorption. We have enzymes in the GI tract or tissues that can break down drugs before absorption. So there are some enzymes that are required to break down drugs because they can be actively absorbed. So the presence of those enzymes are actually very important. Say, for instance, peptides. E.g., peptides are broken down by digestive enzymes. Are we together? So this presence of enzymes are very, very important. It plays a role in drug administration and in drug absorption. Then another one is cell membrane permeability. Cell membrane permeability. So when we're talking about cell membrane, drugs, drugs must be able to pass through some membrane. Okay? Drugs must pass through like biological membranes before they can be absorbed. Take for instance all these lipid soluble, all these non-ionized drugs. They cross cell membrane more easily. Are we getting what I'm saying? So they cross membrane more easily than water soluble. Are we getting what I'm saying now? So cell membrane permeability, it also plays a role. So is there any confusion on all those points? Any confusion on all those points before we move on? So now let's move to the other one. So what's the next slide now? Can you see the next slide? Physical factors affecting drug absorption. Physical factors affecting drug absorption. That's the next slide. I hope you can see it. Let me know. Can we see that slide? Physical factors. So we are done with physiological factors. So let's move to physical factors. Okay, so now let's focus on those physical factors that affect. So there are more about the drug physical properties. So this has to do with drug physical properties, external conditions rather than the internal. We just finished discussing the physiological factors now. So now we want to focus on what? On the physical factors, which has to do more with drug physical properties, the external conditions. So now let's start with number one. Let's start with number one. So the first one is what? Drug solubility. Drug solubility. Sorry, please, just a moment. Sorry about that interruption. So sorry, there's a mistake on that slide. Please, can you still hear me? So that first one, I'm going to edit it later. So please just listen. Can you still hear me? So the first one is going to be particle size of the drug. It should be particle. Yeah, it should be particle. So please, you can write it down. I'll edit and then I will send. So sorry about that, please. So particle size of the drug. So smaller particles. Take for instance now, drugs with smaller particles, they dissolve faster. They dissolve faster and they are absorbed more quickly. Are we together? So when drugs are small particles, they dissolve what? Faster and they absorb more quickly. Do we get that simple explanation? Do we get that explanation? So the smaller the particle of a drug, the faster the absorption. That's what we are trying to explain here. Then drug solubility, that's number two. Drug solubility, the solubility of a drug. Take for instance now, we have a lot of drugs that are lipid soluble in nature. So these ones are able to cross cell membranes faster than water soluble ones. I think I explained recently now. So lipid soluble drugs are able to cross the cell membrane faster than water soluble. So when drugs are poorly soluble, when they have poor soluble, when drugs have poor solubility, that drug dissolves slowly. That's what we are trying to say. So that means it's going to delay absorption. So when a drug has poor solubility, there will be delayed absorption. So that is what I'm trying to explain. Is that clear? Now, another one is formulation. The drug formula, the dosage form can also what? Affect drug absorption. Can also affect drug absorption. So now, example is liquid medications. Liquid. So when a drug is in liquid form, maybe like solutions, syrups, are they not going to absorb faster than capsule? Are they not going to be absorbed faster than capsule? So that's what we mean by formulation and dosage. Please let's respond so that I can know that we are hearing me. So when a drug is in liquid form, please, are we still together? Hello, are we still together? Okay, so that's what we mean by drug formulation. So when a drug is in liquid form, it absorbs faster than solids, capsules, tablets. So when you administer solutions, syrups, that means it's going to absorb faster. Then there are some drugs that are enteric coated. We know a lot of drugs that are enteric coated tablets. All those drugs now, they resist stomach acid. They dissolve in the small intestine, and all these causes their absorption to be what? To be delayed. Then another thing is concentration of drug at the site of administration. The higher the concentration, if a drug has a higher concentration, will it be absorbed faster or slowly? Let me ask us. When a drug has higher concentration at the site of your administration, is it going to have a faster rate of absorption or slower? I'm asking us the question. Thank you. There will be faster diffusion. So when there is higher concentration, that is why that when you give a patient overdosage, that is why it becomes toxic. That's why we have all these reactions to drug overdose, because we have given too much. You have given higher concentration, and that is why there is drug reaction. That is why the drug becomes toxic, because we are giving too much. You are giving overdose. So the higher the concentration, the faster the diffusion, the quicker the absorption of such a drug. So if you want to put a patient on anesthesia, you are giving a highly concentrated, maybe local anesthesia. It will act faster than someone who is just giving a very minute dose. So that's what we mean. Then what about the physical state of the drug? The physical state of that drug. Drug can be solid, it can be liquid, it can be gas. So now let me ask, out of solid, liquid, and gas, which one we absorb faster? Which one we have the faster rate of absorption? Out of solid, liquid, and gas. If the medication is in solid form, or is in gas, or is in liquid, which one will be absorbed faster? Thank you. Gas. The inhalation will be absorbed faster. Take for instance now, you have a patient who is asthmatic. Who is asthmatic, who was rushed into the clinic with asthmatic attack. Do you want to give out such a patient oral prednisolone? Is it the time to give out such a patient oral prednisolone? Will it act fast? Is it the time to give such a patient oral medication? You want to nebulize such a patient. Is that okay? You want to give them B2 agonist, fast. You want to nebulize them, give them salbutamol in inhalation form, because you know it's going to act fast. You know it's going to act fast. You wouldn't want to go and give any form of high hem at that time. You want to give them inhalation. You don't want to give them oral. Is that okay? Okay. So now, nature of the drug vehicle, that's another thing. Nature, thank you, IV. So nature of the drug vehicle. So there are some medication. Let's talk about like additives. Additives or carriers in the formulation. There are some additives or carriers in the formulation itself, in the drug itself, that can enhance or slow down the absorption. So there are some additives, there are some carriers in the formulation of the drug that can enhance or slow down the absorption. So now, for example, take for instance, can you give me an example of oil-based injection? Can you give me an example of oil-based? Who can give me an example of oil-based injection? Oil-based injection, oily injection, paracetamol, thank you. Now, what about water-based injection? What about water-based? Yes, that's oily. Paracetamol is oily. What about water-based? Water-based. Now, thank you. Artemether is oily. Okay, which one is water-based? Let's give me an example. But Diplo, James, thank you. Now, if you are not giving the 2 injection, which one will be absorbed faster? Is it gentamicin or is it which one will be absorbed faster? Thank you. So that means oily-based injection, they take time before it can be absorbed. So it releases, the drug is slow in absorption compared to water-based. So when you give water-based injection, before you know it, it's absorbed faster than oil-based. It absorbs faster than oil-based. So that's what we are trying to explain here. Then the route of administration, that will be the last one. route of administration, the physical consideration. So when you're saying route of administration now affects, this one also affects how quickly or how much drug reaches the bloodstream. How much drug reaches the bloodstream. So which route of administration is the fastest? Who can tell me which route? It's not even IV. Which route? I think inhalation is faster. Yes, thank you. Inhalation is faster, even more than IV. Thank you. Inhalation is faster, followed by IV, followed by high subcute, high hem, and and so on and so forth. High hem subcute. Is that okay? So the route of administration also determines how quickly the drug reaches the what? The bloodstream. So IV, there's immediate absorption, inhalation, transdermal will be slow. Transdermal will be slow. So that is what we are trying to explain here. I hope everybody understands clearly. So can you see the next slide? Drug distribution. Can you see the next slide? Drug distribution. Can we see that? Next slide, drug distribution. So let me know. Okay, sorry, just a moment, please. All right, so let's move on. All right, so now let's talk about drug distribution. So when we're talking about drug distribution, what is that? So from the slide, you can see that it's the process by which a drug, once absorbed into the bloodstream, is now transported. Is now transported and it passed throughout the body fluids, the tissues to reach all its what? All its target organs to reach the site of actions, the storage site, elevation, and so on. So in other words, absorption gets the drug into the blood. That's what we are seeing here. Distribution moves it around the body to where it is needed, or where the drug is being stored. So these are the things we need to know about distribution. And there are a lot of things we need to know about it. It depends on blood flow, tissue permeability, protein binding, drug properties. So it has a lot to do with all these things that I'm mentioning. So drug will go into their target tissue, maybe to their storage site, maybe to elimination organ. So let's move on. What are the factors? So let's talk about the factors that affect distribution. So let's look at it one. So there are all these factors are interrelated actually. So they are similar. So it's just about how you can think. So it just has to do with your critical thinking. How can you think? So when I'm talking about factors affecting drug distribution, the first one will be blood flow to tissues. Blood flow to tissues. So now, when well-perfused organ receive drugs faster. I don't know if I'm making sense here. Well-perfused organ reach blood faster and it receives drugs faster. While poorly perfused tissues receive drugs more slowly. That's what we are trying to say here. Distribution. This is distribution. This is no longer absorption. So please try and understand the context. So blood flow to the tissues actually affects drug distribution. So when an organ is well perfused, say for instance, the heart, the liver, the kidney, the lungs, the brain, they receive faster. These are what? These are the important organs in the body. Are we together? So they are well perfused. So they receive drugs faster. Now, poorly perfused tissues. Can you tell me an example of poorly perfused tissues in the body? They are not really perfused like that. They are perfused, but not really perfused. Who can tell me an example of poorly perfused tissues in the body? Thank you. Skin is poorly perfused. Thank you. Skin, all the fatty tissues, all those bones, they are poorly. So it takes time when you want to choose. That is why it's difficult to choose all those conditions. When you have disease condition that has to do with bone, you have disease condition that has to do with fatty tissues, that has to do with the skin. They are very difficult to treat. That's just one reason why they are difficult to treat. They are poorly perfused. So you need extra work to treat them. So it takes time for drug to become distributed to that area. Or if the patient is in shock, there is reduced blood flow. So it will limit distribution. Then another one is capillary permeability. Capillary permeability. So the when we are talking about capillary permeability, that's more like the ease with which drugs through the capillary walls. The ease with which drugs pass through the capillary walls. Let's say, for instance, now capillaries in the liver, in the kidney, they are very permeable. They are very permeable. So drugs move through them, quickly, easily. Are we together? Then there's something we call BBB, blood-brain barrier. So brain has what? Blood-brain barrier. You know that? You know that brain has blood-brain barrier. So only lipid-soluble or all these actively transported drugs can cross them. So there are actually some drugs that can cross the blood-brain barrier. So that's what we are saying by capillary permeability. Then plasma protein binding, that would be the third one, I think. Yeah. So plasma protein binding. Many drugs bind to plasma proteins. Mainly albumin. Albumin is an example. Mainly albumin. Are we together? So there are a lot of drugs that bind to plasma protein. Are we together? I hope you are together. So when there are some drugs that we have some drugs that are bound drugs that they are in, so they can't leave circulation. Then we have some drugs that are free drug, which are active and can act on tissue. So when we have, I told you that we have an example known as albumin, which is an example of plasma protein. So when we have low albumin level, say for instance now, when you have low albumin level, maybe in case of malnutrition or someone is having a liver disease, that means we are going to have more free drug. That means we are going to have more free drug. Because if there are drugs that needs to bind with that plasma protein, albumin, and you are having a low albumin, the patient is having liver cirrhosis, the patient is having maybe severe case of hepatitis or malnutrition, that means there will be more free drug. And definitely there is risk of what? Toxicity in such a patient. So that's what we are talking about. Now let's move on. We have tissue binding or storage. That's another factor that affects distribution. Tissue binding or storage. Some drugs bind strongly to tissues. Some drugs accumulate in the fats. Together. So let's say, for example, now lipid-soluble drugs. They are stored in the fats. Lipid-soluble drugs are stored in the fat, so there's slow release, there's prolonged action. I'm just using that as an example. Then another example is tetracycline. That one's bind to what? Tetracycline. It binds to bone and teeth. I don't know if that makes sense. So some drugs, they bind strongly to tissues, while some accumulate in the fat. So all these are just examples for us to understand what I mean by tissue binding. What I mean by tissue binding. I hope you are all following me. Hello, are we there? Okay, yeah. So let's move on. Then another one is volume of distribution. Volume. So the apparent volume that the drug distributes. So now, how do I explain that? When we're talking about volume distribution, large volume. So when you have large volume, drug is widely distributed in the tissues. When you have small volume, drug stays mostly in the blood. Let me just put it in that simple way so that I don't confuse us. So when we're talking about volume of distribution, that means the apparent volume that a drug distributes into. The apparent volume, the volume that the drug is. So when you have a large volume of distribution, drug is widely distributed within the tissue. When you have a long volume, we have some drugs that are lipophilic drugs. Lipophilic. So when you have large volume, drug is widely distributed into the tissue. But by the time you have small volume of drug, small volume of distribution, that drug stays mostly alone in the blood. That's what I'm trying to explain. Then physiological barriers. I've spoken about that. Blood-brain barrier. That one protects the brain You can't just, God has created in such a way that not all the drugs that we just give, everything is just going to the brain. The brain needs to be protected. So it has something called the blood-brain barrier. So it protects the brain from many drugs. So this is an example of physiological barrier. So this one can actually affect distribution. Physiological barrier. Another example is placenta barrier. Placenta barrier allows some drugs to cross to the fetus. Allow some drugs to get to the fetus. So that's an example of physiological barriers. Are we together? Does that make any sense? Are we together? Okay, now, so let's talk about, I think age is there too. Age, yeah. So in age now, in infants. So let's use infants and elderly. Those are the extreme we have. The elderly. Infants, they have immature barriers. They have immature barriers. So drugs distribute more widely. Drugs distribute more widely in infants. So there is high risk of substance. So that's why we don't joke with drug administration in infants and in the elderly. If you make any stupid mistake while administering drugs to these extremes of age, they will die. So they have immature barriers. So you have to be very careful. So there is risk of toxicity. Now for elderly, there's reduced protein binding. There are a lot of altered tissue composition in elderly. They have less muscle. In elderly, so you don't joke when administering medications to them. So this is one of the factors that can affect. So you put this into consideration when it comes to what? Drug distribution. Are we together? I hope I'm making a lot of sense. Okay, then the last one is what? Disease states. Disease states. So liver disease, if someone has liver disease, if someone renal failure, all an altered protein level. Say for instance, in the patient with liver disease, in the patient with renal failure, there is altered protein level. These patients have edema. There is shifting of fluid. There is thought spacing. There is fluid shifting from blood vessels into the interstitial space. So all these can affect drug distribution. Or maybe a patient with heart failure, there is reduced output. In a patient with heart failure, is there no reduced cardiac output? So there is decreased perfusion to tissue. So these are the things that falls under what? Under disease states. Does that make any sense? So let's move to metabolism, because I don't want to waste our time. So let's move to drug metabolism. So when we're talking about drug metabolism, what do we mean? Drug metabolism. So drug metabolism is also known as biotransformation. Biotransformation. So drug metabolism is the process by which the body chemically alters a drug into another form. Are we together? So we call that form a metabolite. So when that drug is being altered, we call it metabolite. In order to make it easy for elimination, that is just the reason why. So we just want to make it easy for what? For elimination. So in simple terms, we can say it's the body's way of breaking down drugs so that they can become inactivated or removed. So now, metabolism happens where majorly? Where does metabolism take place majorly in the body? Who can tell me where does metabolism take place? Where in the body? In the liver, yes. Thank you. Majorly, most metabolism takes place. Although it can happen in the kidney, in the lungs, even intestine, in the skin, but the major site where metabolism takes place in the body is the liver. And the main goal is to convert the drugs into a more water-soluble form. So that's the goal of this metabolism, so that it can be easy for the kidney to either excrete, or is either to make that drug to become inactive, or inactivate the drugs, maybe to reduce their activity. Although some metabolites may still be active, or sometimes it can either be to activate, there's something we call prodrugs. It can either be to activate the prodrugs. Inactive, but when we are saying prodrug, that means inactive form that becomes active. There are some drugs that are in inactive form, and after metabolism, they become active. Example is codeine. Example is what? Codeine. So I hope you are following. So now let's quickly just talk about phases of drug metabolism. So we have phase 1, which is known as the modification phase, or we can say functionalization reaction. So during this phase, now, I told you that metabolism takes place in the liver, and it can also take place in other parts of the body. So now, in phase 1, that phase 1, what happens in this phase 1 is that it's more like they are this phase 1, there is more like unmasking of functional group. This is not biochemistry class. So we wouldn't be going into all those chemical compounds. Are we getting what I'm saying? So it's just to, since I've joined, can't hear or see anything. Hey, I hope everybody is hearing me. Who call this ball? I'll drop the recording video. Okay, no problem about that. Maybe it's your network. Sorry. Sorry about that. Maybe it's your network. Okay. So this phase 1, I'm talking about phase 1. That means the drug is chemically changed to make it slightly more water soluble, ready for the next step. So it's more like introduces or mask like a functional group of a drug. And this particular stage, what takes place actually is what? Oxidation, reduction, and hydrolysis. I don't know, somebody's mic is on. I don't understand. So please, let's mute ourselves because I've muted everybody. So I don't know why I can still hear background noise. So what really takes place in this, so what takes place in this particular phase 1 is what? Oxidation, reduction, hydrolysis. So let me quickly just define those. So when we're saying hydrolysis, hydrolysis is the breaking down of chemical compound or chemical bond in a drug molecule by addition of water from hydrolysis. So if you're a science student, you definitely know this. So that's what we mean by hydrolysis. Then when we say reduction is maybe removal of oxygen from drug molecule. That's just what takes place. So there's removal of oxygen. While oxidation is what? Is the addition of oxygen to a drug molecule. So these are the things that actually takes place in this phase 1. Oxidation. So just know that in phase 1, there is oxidation, there is reduction, and there is hydrolysis. And then there is a major enzyme in the liver. So that's the name of the enzyme. We call it cytochrome P450. We call it cytochrome P450. We have several of them. We have different types of this enzyme in the liver that metabolizes different types of drug. But that is not our concern. But just know that in the liver, there is an enzyme called cytochrome P450 that metabolizes different medications. So this is not a chemistry class. So we are not going into all those parts. So now, just have it at the back of your mind. So majorly, it is this enzyme that acts on medications. And the outcome here is what? The outcome, what we are after here is what? Is maybe to inactivate the drug, to either make it more active, or to prepare it for what? For phase 2. So is that okay? So please just have that at the back of your mind. So that's all I need you to know in this phase 1. That is all I need to propose. The reactions that take place, which are the oxidation, reduction, hydrolysis, and the enzyme that metabolizes drug. We have different types of them. Is that okay? Now let's go to phase 2. Let's go to phase 2. So can you see the next slide? Phase 2. All these people that are dropping their matriculation. If I block you, you'll not be able to join my class again. You're just distracting us. Instead of you to listen, you are dropping matric number. I don't know what I want to do with your matric number right now. So can we see the next slide? On phase 2. So that phase 2 is known as what? Conjugation phase. So we can call it the conjugation phase. So here the drug or the phase 1 method. You know, we already have a metabolite in phase 1. So here, this is where conjugation takes place. So drug or its phase 1 metabolite is joined with another, with a large water soluble molecule. So here, the major actions that take place, or let me say the major reaction that takes place is what is known as what? Glucuronidation, 1, sulfation, acetylation, and methylation. So when you look at it, that glucuronidation, that means the addition of glucuronic acid. So let me divide that for us. So please don't see it, it's not a big deal. Addition of glucuronic acid. Are we together? Someone said no, ma. I don't understand the no, ma. So now, what takes place is the addition of glucuronic acid. So from sulfation, what do you think? Addition of what? Let me ask first. So that we don't get confused. Sulfation is what? So I define glucuronidation. I want us to get it. Addition, there's addition of glucuronic acid. Thank you, sulfate. God bless you. Then acetylation will be what? Acetylation is what? acetylation and methylation. Thank you. That's just it. So they are very simple. So main reaction that takes place in phase 2 is glucuronidation, addition of glucuronic acid, addition of sulfate, addition of acetyl, addition of methyl. So that is what takes place. So it just makes the drug to become more easier to excrete. So the outcome is usually what? Completely inactivates the drug and makes it more ready for what? Excretion. So that is just the tool. So don't get confused. Just have those simple understanding about this phase 1 and phase 2. So that is a diagram for you just to use. This is just a diagram to summarize what happens in stage of metabolism. So you can take your time to look at it. So that's just it. So now let's quickly talk about factors that affect drug metabolism. So can you see the next slide? Hello, can we see the next slide? Can everybody see? Okay, so what are the factors that affect drug metabolism? So age is also there. Since we now know the meaning of metabolism, we know where it takes place. Age is number 1. So factors that affect drug age. So in newborn and infants, they have these immature liver enzymes. So you see now. So newborns have immature liver enzymes. So there is slower rate of what? Metabolism. Are we together? There's slower rate of metabolism in newborn, in infants, because they have immature liver enzyme. This cytochrome that we are talking about, that particular enzyme, is not matured enough in their windows. So that is why we are very careful when we are giving them medication. So there is higher risk of what? Toxicity in children. And in elderly too, there is reduced liver mass. There's reduced blood flow. You know, elderly people have a lot of challenge. There is a lot of physiological changes in their body. The liver is not really as active. It's deteriorating. There's problem with blood flow. There's problem with enzyme activity in elderly people. So they have slower rates of what? Of metabolism. So that is why when you mess up, you make a mistake in giving them medication, they can quickly react because there is higher risk of toxicity in these extremes of age. Now let's go to the next one. Genetic factors also affect drug metabolism. So there are some variations in gene. We know we have different genetic makeup. So there are some variations in gene coding, maybe for metabolic enzymes that affect metabolism speed. Take for instance, some people naturally they metabolize drug faster. Let me just put it that way. Are we together? So they metabolize drugs faster than others. So it's just like a kind of genetic makeup. Maybe it's this particular enzyme differences that is actually playing out that role. Maybe it's that one that is going to explain why some patient responds differently to the same drug. So when you give drug to patient A, you give drug to patient, and that is why as nurses, you don't compare your patients. You don't say, is this the medication that Mr. Lagbaja took and is doing well, and you are no. Because there are some genetic makeups, maybe as a result of this particular enzyme in the liver, maybe that is what is going to explain it to us. So why some patients react differently to even the same drug. Are we together? Does that make sense? Does my explanation make sense? Now let's go to the next point, which is text. Hormonal differences can also affect metabolism. Have that at the back of your mind. Hormonal differences in different gender, it can affect metabolism. There are some drugs that metabolize more slowly in women due to their lower enzyme activity. So our gender also affects it in a way. Then liver function or disease, we all know that. When the liver is dysfunctioned, do you expect it to metabolize drugs? So when the patient has liver cancer, there's cirrhosis, there's reduced enzyme activity. That enzyme that is breaking down, that is helping to metabolize drugs. So this patient has lower metabolism. That is why a patient with liver disease. Can you tell me an example of hepatotoxic medication that you should avoid in a patient with liver disease? One example of hepatotoxic medication. The simplest one. The simplest example of hepatotoxic. Paracetamol is the simplest example that we can lay your hands on. So now, take for instance, you don't want to load such a patient with paracetamol now. So that is what we are talking about. That's what we are talking about. So now another one is enzyme induction. So there are certain drugs, maybe certain drugs or chemical, they increase liver enzyme activity. Yeah. So drugs are broken down faster. So that's what we are saying. Example is rifampicin. Drugs like rifampicin, drugs like alcohol. Yes. Drugs like alcohol, drugs like rifampicin, even carbamazepine that we use, they induce the activity of what? Of enzyme. They increase liver enzyme activity, and this also affects what? Metabolism. So that's it. Then another one is enzyme inhibition. So it's just the opposite. Some drugs will actually block the enzymes. They will block it. So drugs are broken down more slowly. So they increases the risk of what? Toxicity. So any drugs that inhibit what? Enzyme activity will lead to what? There will be slower rate of metabolism. So that's what we are trying to say here. Take for instance, there are some medications that when you give, like erythromycin, grapefruit juice, when you give, there is a way they inhibit liver enzyme activity. So that's it. Then nutritional status. Let me change to the next slide. So we'll be running on very soon. Okay, so nutritional status. So nutritional status, what I mean, how can it affect metabolism? Malnutrition, where there is lack of protein, vitamins, all these essential nutrients, minerals. So they reduce the activity of enzymes. Is that okay? They reduce the activity of enzymes. Sometimes high protein diets can enhance metabolism. High protein diets sometimes they can enhance metabolism. The environmental factors too can actually affect it. Smoking. Smoking induces liver enzymes. Smoking reduces liver enzymes, like it brings about faster metabolism of drugs. Take for instance theophylline. So smoking is an example. Alcohol, like I said now, it induces enzyme. Exposure to some chemicals like pesticides, they may also alter drug metabolism. Is that okay? The route of administration, oral drugs undergo what? Oral drugs will definitely undergo what is known as a first pass. There's a first pass effect, metabolism in the liver, before it now reaches the systemic circulation. So there is reduction in their bioavailability. Are we getting what I'm saying? But parenteral drugs, most of the time, parenteral medications, IV, IM, they will bypass all these stuffs. They will bypass all this process. So that is what we are talking about. Then other disease conditions, like we have different disease conditions in the body, cardiac failure, shock, thyroid, a lot of disease conditions that can affect metabolism, that can slow down the rate of drug metabolism. So lastly, to wrap it up, we're going to be talking about drug elimination. So we're going to be talking about, so what is drug elimination? It's just the process by which the drug is removed from the body, either as the unchanged drug or as metabolites. Is that okay? So let me look at the definition on the screen. Drug elimination is the process by which a drug is removed from the body, either as the unchanged drug or as metabolite. So the removal of the drug from the body may occur through a number of routes, and the most important of them is the kidney into the urine. The other routes are bowel, intestine, lung, or breast milk in nursing mothers. So let's look at major routes of drug elimination right now. The kidney, which is the major route. So drugs are excreted in what? In urine, maybe by glomerular filtration. So this one filters what? Free drugs are filtered here. Then another thing is tubular secretion, where we talk about active transport of drugs into the urine. When we are talking about the kidney, we have the glomerulus, the tubules, all those stuff. So the third one is the tubular reabsorption. So some drugs definitely they are reabsorbed back into the bloodstream in the tubules, depending on which part of the tubule. We have the collecting tubules, we have the distal convoluted tubule, we have the proximal. So some drugs are actually reabsorbed back into the bloodstream depending on their solubility, maybe on their pH. So this is what we are talking about on the renal part. Then the hepatic. Hepatic, here, drugs or metabolites are excreted into the bowel. Then from there into the what? Into the feces. Are we together? So I hope we are getting what I'm saying. Are we together? Then lungs. So lungs, volatile drugs and gases are eliminated via what? exhalation. Example is general, what's it called? General anesthesia. Yes. Example is general anesthesia, even alcohol. So that is an example. So let's move to the next slide. The other minor routes. So I hope you are following. So other minor routes, we have the sweat and the liver. So small amounts may cause taste disturbances. We have the tears. Can we see breast milk, skin? I hope you are following skin. So these are the routes by which drugs might be what? Eliminated. Now, so lastly, let's talk about the key parameters in drug elimination. Half-life. So please, you need to know the meaning of all these. Half-life, that is the time taken for plasma concentration of a drug to reduce by half. So it determines the dosing frequency. So this helps us to determine what? The dosage of a drug. So the time taken for plasma concentration of drug to reduce by half. That's what we call half-life of a drug. There is no other explanation to that. Then clearance. That is volume of plasma cleared of a drug per unit time. Is that okay? And that reflects the efficiency of what? Of elimination. To what? To check the efficiency of the kidney. Do we get that? So they will say, okay, patients should do creatinine clearance test. So that is one of the things. It reflects the efficiency of kidney of the liver. So that is also it. So we have come to the end of the lecture. And thank you everyone for listening. I don't know if there are questions. For those that couldn't hear, I'm sorry about that. So maybe you can listen to the recording. So, any question? Yeah, you can drop your question. Yeah. So let me stop the recording so that's